Hi everyone. I hope you can hear me okay. I'm just going to give it a few more seconds to allow people to join and settle in, and then we'll get going. Okay. Good evening, everybody. Thank you for joining us tonight on this hot evening. I hope everyone's not too hot and you can stay nice and cool. I'm Nicola, or Nicci, and I'm one of the specialist nurses here at Pancreatic Cancer UK. So I'm pleased and delighted to be joined today by a consultant in palliative medicine from City Hospice in Cardiff, Dr James Davies, who will be discussing palliative care and planning for the end of life. Before we get started, there are a few quick bits of housekeeping to run through. I'll also share some information about the support we can provide you and your family at Pancreatic Cancer UK. So the housekeeping, there will be a Q&A session during the middle and at the end of the webinar today. You should see a Q&A icon on your screen, which looks like two speech bubbles. To ask a question, just type it into this box. Feel free to ask questions throughout the session, and there's no need to wait until the actual Q&A part. If you are joining from outside the UK, you're very welcome today, but please keep in mind that the information we give will be will be based on the UK healthcare system, and we won't be able to advise on options elsewhere. This webinar will be recorded and will be made available on our website afterwards if you would like to watch it back or share it with other people who might be interested. Please be aware that any questions you ask will be visible to all attendees today. You can choose to ask a question anonymously if you'd prefer, and you can upvote questions by clicking on the thumbs up button. This will boost them then to the top of the list. There may be questions that are highly specific or fall outside the scope of today's webinar. So that we can keep the questions we answer relevant to as many people as possible, we may in these cases reply in the Q&A box, offering signposts to support and information, or encouraging you to call us nurses on the support line rather than reading your question aloud. Okay, so I just wanted to talk to you briefly before we make a start today about the services that we offer here at the charity for people affected by pancreatic cancer. I'm aware that many of you joining us will be already familiar with perhaps a couple, if not all, of the services, but for those of you that aren't, this is a quick introduction for you. So our support line is run by myself and 6 other friendly nurses with a wealth of pancreatic cancer experience between us. You can contact us about anything, managing symptoms, questions about your diagnosis, treatment options, or just to talk about how you're feeling. Your family members and friends can call us too, as can healthcare professionals. So you can see the telephone number there on the slide now, along with our email address and opening hours, and we'd love to hear from you. We also have a wide range of information available for you, from short videos about pancreatic cancer and what having chemotherapy or surgery might entail, to lots of information on our website about treatment, managing side effects such as fatigue and taste changes, to fact sheets and booklets covering all these topics and more. The publications are free to order and can also be downloaded to read at home, and you can find these from the information link on the slide or from our website under the Support for You tab. We also host webinars and also online support sessions on a regular basis, covering a wide variety of relevant topics. So you can find all the information you need on our website. They're really easy to book on. And if you do need any support in using Zoom to join the sessions, then we can talk that through with you. The sessions are really relaxed and informal. So as well as being able to ask any questions you may have, it's also a good opportunity to meet others who've been diagnosed or are supporting someone with a pancreatic cancer diagnosis. And finally, we have our discussion forum. So the forum is accessible 24/7 and there is a supportive community there online. You can access the forum via our website. The link is on the screen there, and it's a simple process to register. We do just ask that you read through our forum guidelines before posting. Okay, and now I'm very happy to hand you over to our guest speaker today, who is Dr James Davies from City Hospice Cardiff. Welcome, James.
Well, thank you for that introduction. Thanks for having me. I think I've done a couple of these now, and it's always nice to come along. And hopefully, the aim of the session really is to is to be helpful for, for people, for patients, and also relatives going through what is a really difficult time, and hopefully to dispel some worries and things about what palliative care is and about what we can offer, and by the end of it, hopefully see the benefit of palliative care input, and to see it as a positive. So I'm going to try, and this may be the most difficult part, I'm going to try and use technology and see if I can share my screen. Can you see that okay?
Yeah, we can see that.
Okie dokie. Now, apologies, I just need to, there we go. There we go. Can you see that there? Okay.
Yeah, we can see that, James. That's great. Thank you.
Lovely. Okay. So, first of all, I'd just like to say as I've said, it's a pleasure to be asked to talk here, and I think that this is an incredible resource the Pancreatic Cancer UK have. So as we've spoken about, is trying to tap into that resource and to use it to your advantage. And I always say to any patient I meet, whatever their diagnosis, if in doubt, ask somebody, because often it feels like you're sort of in the dark, you don't know what's going on, and you ask somebody and there's that instant relief of actually, this person knows what I'm going through. So a brief who am I? My name's James Davies. I'm a consultant in palliative medicine. I work for an organisation called City Hospice. So we're a community team. So although we've got hospice in our name, we actually work predominantly in people's homes. But just to say, I'm not unique. There are lots of me around the country, and there's lots of palliative care teams, and everywhere in the UK should have access, or people across the UK should have access to palliative care and to the support they can offer. So what are we going to look at? So the first is, what is palliative care? And I think that's probably an important one, because often the thought is, well, palliative care equals end of life care, which, we do look after people at the end of life, but a big part of this is thinking about, well, actually, with the time we do have left, we want to do some living, and we want to do that as well as we can, and palliative care can be a big part of that. Just hopefully a bit of a selling point for the benefits of palliative care. And then thinking about, part of this has to be quite, I have to talk quite generically, because I know specifically around by me who does what, but in your area you will have a certain setup which is unique to your area. But just thinking about, in general, who delivers palliative care and what you can expect from that palliative care team. We're then going to have a Q&A. And after the Q&A, there'll be a separate section on end-of-life care. I deliberately put that as a separate section because I realised that that's probably, for some people, quite difficult things to think about and talk about, and now might not be the right time. But hopefully, if it's on the webinar here and it's recorded, you can come back to it and have a look when it does feel like the right time. And then another sort of question and answer. And the last times I've done this, I think probably the most enlightening bits, rather than hear me talk, is actually the question and answers, and it seemed like lots of people had the same questions. So please, encourage you to use the chat and to ask questions, and hopefully I'll do my best to answer them. Right, so what is palliative care? I put this one up because I think palliative care often conjures up fear and worry about, well, what does this mean? Does this mean end of life care? Does this mean, that myself or my loved one is about to die? Often, or the majority of times, actually, that isn't the case. That someone's been referred to palliative care for a specific reason. It may be a specific symptom they have, to have just that psychological support, social support that people need. Often when I meet people in clinic for the first time, I give them about 10 or 20 beats a minute extra on their heart rate than would be normal, because I know I induce anxiety in people. I don't take it personally, because hopefully by the end, once we've spoken about actually what are we going to do, it's usually a positive experience. So usually they don't go out looking like this. So the reason I put this up is to hopefully not be afraid of palliative care and not worry if somebody starts talking about it, but just to explore actually what does that mean? How can that help? And where am I, or where is my loved one in their illness? What can they possibly offer to enhance their quality of life at this time? So I think I've covered some of this. I think, we've got hospice in our name in City Hospice. Lots of places will have that word in there. As I said, we're actually not a bedded unit. We don't have beds for patients to come into. We work with people in the community, but people can often assume, well, it's a hospice, so people go in there for end-of-life care and they stay in. And I've learned that people are very trusting. I remember one gentleman turning up with a bag for his first assessment, thinking he was coming in to stay, even though there was no reason for him to. He was just very trusting that, well, if that's what you say we need to do, that's what we'll do. And then the other thing, hopefully, that palliative care offers is, I often find that people can feel abandonment or a feeling of loss when they've been so involved potentially with, if they've had treatment. Some people don't have treatment, but if they've had surgery or they've had chemotherapy, they're very, very involved in those teams. And then suddenly it's kind of, well, there isn't anything else we can do. We're discharging you to palliative care. So they can feel like that transition as a loss and someone's giving up. Well, hopefully over time, that relationship with palliative care will then grow. And often there's an overlap that someone is having their treatment, but they're also then having palliative care support. So there's not that feeling of well, what now? Also important just to say that if somebody's not having treatment, that doesn't mean that they're not having care. It doesn't mean that people don't care and that healthcare doesn't care. It just means that for that individual person, treatment is no longer the right thing, or that person has decided that that may not be the right thing. But you should always expect and receive good quality care, whether you're having chemotherapy or surgery or not. We look after people with life-limiting conditions. So that obviously includes pancreatic cancer, but a lot of other conditions as well. But as I said, it's not just people who are having treatment, but often we do look after people who are receiving treatment. So it can seem a bit of a strange concept to be having treatment, be having scans, be under an oncology team, or have had surgery, but also be having palliative care. Just to say, it's not all or nothing. The two work alongside each other, and we work very closely, on first name terms with our local oncologists, and work closely with the aim of trying to improve this person's life, to maximize their quality of life. And also, I find that the oncology team, the surgical team, have got a very clear focus on what they're trying to achieve. And this isn't to be disparaging to them at all, because you wouldn't want me being a surgeon. I wouldn't do a very good job. But hopefully we're looking at people on a sort of a broader basis, and actually, what is that person's goals? Is that something as simple as they want to go in the garden and do some planting? Is that they want to go on a holiday? These sorts of things that can take a bit of a back step when everything's very treatment focused. Actually, these are very important things. And the other thing that we do is plan for the future. And that does include end-of-life care. So I think it's important for me not to sugarcoat that, because I think it would be unfair of me to say, no, we don't do that. Because I think as healthcare professionals, we try and protect people. We try and not hurt them. We try and not upset them. And we think that actually talking about these things will do that. The reality, the majority of times that I see, is actually you get the opposite thing. That talking about these things at the right pace, at the right time, with the right person is empowering and is a huge weight lifted off. So that's another part of our job, which I think is very important and something I wouldn't be afraid of. So this is when I do any sort of teaching about palliative care, this is sort of the main things that we hopefully try and address. And what that looks like for each individual person or each individual patient is going to be very specific. But in general, we're looking at the physical. And I think that when you go and see a doctor, you go and see a nurse, you're probably thinking, well, they're going to ask me about my pain, they're going to ask me about my sickness, the physical things. They're incredibly important things, and they're things that we're trained to do. And that is one of the mainstays of what we do. But it's broader than that. It's thinking about, well, actually, what is the impact of this illness on the people around that individual? So how is that affecting a wider family, a wider network of support? How is somebody, if because of an illness, they're becoming progressively more frail and more unwell, how are we going to manage that? How are we going to support them to be able to stay at home if that's what they wish to do? How is that going to work? Because as time goes on, more physical things have a social impact. And you know, I'm certainly not telling you anything at all that you don't know here, but the emotional impact of a devastating diagnosis, not only on that person but on loved ones as well. And how do we help with that? How do we support that? And then there's sort of things like spiritual and cultural care. To me, that's kind of the thing. How does that person interact within their community, and what makes that person an individual? What's really important to them? I remember looking after a chap who he was a massive Arsenal fan, and we actually approached Arsenal initially just for some signed photographs, but actually they sent t-shirts, football shirts for him, football shirts for his children and things, and that absolutely made his day. Better than any medication I could have ever given him. That made his day. So those sorts of things are really important to us in palliative care, to try and get to know someone as an individual, and how do we make this person's life better. We may not be able to prolong someone's life significantly, but we can certainly make it better, and that's what it's all about. So what are the benefits of specialist palliative care? So this is my sales pitch for specialist palliative care. So going back to the slide before about actually what is it we try and tackle. So I would certainly hope that if yourself or your loved one is under a palliative care team, that their symptom control would be better managed. Sometimes that can be difficult, and it takes a little bit of time to get symptoms where we want them to be. But having somebody looking at that, I think, is really important. So symptom control, improved quality of life, the psychological support, and that will look different wherever you are. But where I work, we've got sort of counsellors and things that can help not only patients but family members, and sort of the wider network that is helping care for this person, because we recognize the importance of that. But I think as well, one of the real major things that I get the sense and the feedback from people that is a relief when we first meet people is actually that there's someone we can call. There's someone, you know, this is so complicated. I've got so many people involved. Who do I call for what? Well, actually, that person could be the palliative care team. You know, they could fulfill that role. We're very used to working within a very complex network of health and social care. Sometimes the assumption is that everybody knows that, but it takes years to learn that. So actually having someone who you can phone up and say, well, look, I'm really struggling with this. I'm really struggling to get out the house. You know, the steps are now like Everest, but I want to get out the house. I want to be able to go to the park. I want to be able to go to the pub, you know, whatever it is, then actually we'll know quickly who to contact. There is some evidence as well that if you're under palliative care, that patients are less likely to be admitted to hospital acutely. That's not to say that if somebody is unwell and it's appropriate and that's what they want to go into hospital, we wouldn't stop that happening, and being under palliative care wouldn't stop that happening. But it's for the people actually who don't want that to happen, then we can help with that. And as I've sort of alluded to, it isn't all about end of life care, but that is about a part of what we do. So I put this in just because I think it's just to represent. I think it's a nice picture which says, well, actually trying to navigate this is like an incredibly stormy sea, and you know, sometimes we can feel like a rickety old boat. From a personal level, I've been in the position of having loved ones who have had an advanced cancer and approaching end of life, and even being a doctor and working in healthcare, it's still hard. So sometimes it can feel like this, and hopefully with the help of palliative care, working with you, your loved one, and the wider health and social care network, we can try and make that sea a little bit calmer. This slide is just to illustrate the point about the overlap. So sometimes it can feel a bit all or nothing, you know, that actually, well, no more treatment now it's over to palliative care. Well, but there's often, not always, but there's often a transition point where actually you're still having treatment, but if those treatment options are running out, or the treatment isn't doing what we want, or you or your loved one decides, actually, I don't want any more treatment because the side effects are getting too much, or actually my focus is somewhere else, then it may be then that transition point of, well, the focus has been very much on the treatment aspect, now becomes more actually palliative care are taking the lead. But it's important that someone is taking the lead to help support you. And then often there's a point where actually there is no further treatment, and it is actually, this is about terminal care. I think is quite a harsh way of putting it, but it's about sort of good quality end of life care. Right, so who delivers palliative care? So I work for a specialist palliative care team, so I'm trained in palliative care, but lots of people provide palliative care. There's sort of a concept, it's not that important, but generalist and specialist palliative care. Generalist palliative care is, to me, is delivered by anyone caring for someone with a life-limiting illness. And to me, probably the most important people are not healthcare professionals at all. It's the people that are with a person day to day, and they are sort of often the linchpin, supported by health and social care. Specialist palliative care is delivered by specialist palliative care teams, in which I work, and I'll talk a little bit more about what we've got in our team. But I would say that if someone has pancreatic cancer which is not treatable, I would expect the majority of people actually to be under a specialist palliative care team, just to be able to manage that person's symptoms and to look at them as a whole. As I said, it feels like a stormy sea. There's so many people involved. Who does what? You know, who do I call if I've got this problem or this problem? We recognize that. So when we first meet people, we actually give them a bit of a cheat sheet, I call it. So it's got sort of the main different people involved, the oncology teams, the GP, the out of hours, ourselves, district nurses, kind of a broad outline of what people do. But the one thing I always say is, look, if you're in doubt, pick up the phone to somebody, even if it's not that person who is in the best position to sort it out. They'll either be able to contact who they need to, or signpost you to the right place. So I think the treatment or the advice line, sorry, in the charity here, I think is probably a really good resource, just to say, like, I've got this problem, who do I talk to? And usually that's the first step, and the most important step for you to be able to try and resolve whatever it is which is troubling you. So surgical teams often, during the time of diagnosis, and especially obviously if surgery is planned, if the cancer is operable, then surgical teams will be involved. Unfortunately, with pancreatic cancer, the majority of cancers will not be operable, but the surgical teams are often involved in that early stage. Oncology teams, if somebody is well enough and wishes to have active treatment such as chemotherapy or radiotherapy, then or trial treatment, that would be under their remit. And usually, depending on where they are, usually they would be sort of a key worker. Usually that is someone called a clinical nurse specialist, but it may differ depending on where you are. So that would be the go-to person for questions specifically related to cancer treatment or follow-up. For me, working in the community, I can't do my work without the community, the healthcare professionals in the community. So the GPs oversee medical care in the community. So if somebody phones in and there's a new problem that isn't necessarily related to their cancer, or they may have an infection, something like that, often what our nurses will do is say, well, probably better to get in touch with a GP, because you're going to need a doctor to review you to see what we need to do from here. And also they're the ones who provide prescriptions. They're also very important in end-of-life care at home. So we don't take over from the GPs, and I would expect your palliative care teams locally, wherever you are, to not take over, but to work alongside them. There's also out of hours, because obviously the GPs only work generally, I'm just talking broadly here, but maybe between 8 and 6 o'clock. So, and invariably things seem to go wrong in the middle of the night. And you know, if it's not an emergency, then actually you're probably better off getting to the going through to the out of hours GP that is available at nights and weekends to review and see what needs doing. We work very closely with our district nursing colleagues. So these are nurses that come out to the house. They're available 24 hours a day, but it is dependent on staffing levels, how quickly they'd be able to get there. But we often, if somebody, especially if they're deteriorating and they need, for example, medicines for symptom control that can be given under the skin, or they need monitoring of pressure areas, there's lots of roles that they would play. They would be key to that. And locally to us, they also arrange the care if somebody is deteriorating quite quickly. So they have an important role, and people that if you or your loved one are deteriorating and you wish to stay at home, that I would expect to be involved along with the GP and the palliative care team. So specialist palliative care, often charities. I work for a charity. We're a local charity, but it depends where you are. You'll have a different palliative care team which covers your area. Broadly, there's a community team, an inpatient team, a hospital team, and a team for a specialist cancer centre. Sometimes they can be the same team and they cover across. Where I work, there are separate teams for each. Doesn't really matter to you guys. The most important thing is to say that you should be able to access palliative care in any of those settings. The inpatient hospice, people often worry about going into a hospice thinking, well, am I going to come out of a hospice? Yeah, they do look after people at the end of life, but often we admit people for symptom control. If this is really difficult for whatever reason at home, having somewhere where they can go where there are nurses 24 hours a day and doctors daily to review things often is the best option. On the bottom link there is a link to, you can put in sort of your local area, your postcode, and find what your local hospice would be, because I think certainly at the hospice I work at, if somebody wants to explore whether hospice care or palliative care would be helpful, we'd be more than happy to explore that. So if you're unsure and just want to get an idea of what they do, then I would go there and then ask, just find out who your local hospice is. They should have their contact details, and you can speak to somebody. It'll depend on the local hospice what they would do from there, but at least it's sort of a starting point. The other thing is to say that if you're under a key worker, a sort of a specialist nurse, and you feel that actually palliative care or hospice care may be helpful, then I would speak to them, because they will have very good links to the local teams. So this is just to say that there's lots and lots and lots of different hospices. I had to put us front and center. It's a bit of another shameless selling there, but there's lots of different places with different names. The overarching aim and the overarching way of caring for somebody should be the same. We should be looking after somebody as a whole. How that's done will depend locally on what services there are, but you guys should expect a high quality service looking after somebody with a life-limiting illness, and look after them and their loved ones as a whole, and try and improve quality of life. So what to expect from specialist palliative care. So I always make a bit of a joke when I first meet somebody that that it's like the Spanish Inquisition. So I ask lots and lots of questions. When the nurses go back, it must be a relief because they don't have to go over all the same stuff. But I would be asking questions to look at at what things are troubling this individual. What things do I need to do today? What things can I envisage for the future that may be difficult, and how can we help? So again, it's looking at that sort of holistic care. So looking at the physical, the psychological, the social, the spiritual, doing all that, but also offering planning for the future. So I will almost invariably offer to talk about the future, but if somebody isn't ready for that, unless there's a very specific reason, usually that person is very unwell and we need to make a decision today, we'll put that to one side. That's fine. We can revisit it. But I find that that offering that at the outset and just explaining we need to think about this is, I think, for me, just part of the next sort of point I've made is about honest and open communication. So you guys tell us what's been troubling you. You know, tell us openly what things are troubling you. What things would you like us to try and help with? And then for us to be honest about how we can tackle that. And I, you know, again, being honest, we can't always solve everything, but we will try our best and do our best to try and work around things. Usually at the end of a sort of the consultation, we'll have a plan. This is what we're going to do. And usually that involves linking in with other services, bringing in other members of the team. It's going to depend on the individual what specific things those are. But really importantly, I give someone for us, it's a yellow card. Obviously, where you are is probably going to be different, but a contact detail. Who do you call in hours to contact palliative care, and who do you call out of hours? I think that's really important, you know, to get that. Well, who do I talk to? What can I expect when I ring? And so we've got that from the outset. Actually, this is how it's going to look in terms of support going forward. Yeah, so I think I've covered. I've sort of covered that. So pick up the phone, have a chat with your palliative care teams. Usually, they shouldn't be scary or they're in the wrong job, and I'm sure they'd be happy to help. So just really quickly in terms of what we do at City Hospice, just to give a general overview of what a palliative care will do. We get referrals from lots of places, so predominantly from GPs, oncology teams, surgical teams, which is understandable looking back at actually who's involved in someone's care. When I'm seeing someone, I usually see them with a doctor and nurse. That will vary depending on where you are. Lots of places won't have a doctor on the first assessment, but I'm asking about pain, nausea. You can't get away without meeting a doctor and them asking about your bowels, their appetite, their breath, your breathing, the things which are troubling you physically. But how is this working? How is this individual? How is this person coping? How are they living? What's their support network? And how is this illness impacting on them and their loved ones? And then, as I said, we're sort of thinking about offering planning for the future. And really importantly, the last two bits actually are, what are we going to do? It's easy for me to say, I want to prescribe this medicine. Okay, I'm just going to prescribe this medicine. There you go. But actually, if that isn't going to work for that individual, there's no point in me doing it. So it's very much about collaboration and mutual working. And then really importantly, actually, has that person got any questions? I may have missed the most important thing for that person. There's one chap who I looked after. Actually, the most important thing was what happened to his dog after he passed away. That was a much bigger issue for him. Not something I would routinely ask, but actually, okay, that's the thing which is troubling you the most. Let's go and sort that out. And actually, a lot of our staff have animals that they've adopted over the years. So yeah, so we try and do our best. So how do we address these issues? So obviously medicines are important for the physical and sometimes for the psychological impact. I've mentioned there about morphine because people often are very wary about morphine. I completely understand why. Usually people say, well, I'm worried about addiction or thinking about it as end of life care. We do use it at the end of life, but we use it a long time before as well. So as long as we're using it appropriately, it isn't going to shorten anyone's life. But hopefully if somebody's got symptoms like pain or breathlessness, it will improve their quality of life. We also have counselling and reflexology. I actually had some reflexology myself just to see what it was like, and I actually fell asleep during it. It was very relaxing. We have an occupational therapist for that practical social aspect, as well as a social worker. The other thing I think which is really underestimated is about the financial impact that can come, or that does come with an illness like pancreatic cancer. So with us, we've actually got two people called welfare rights officers who look at benefits and things like a blue card badge. They're not the kind of things that a surgeon would necessarily ask, and I wouldn't expect them to. But they may be things which are really important and can really help. So locally to you, there should be some avenue of support there. And then going forward, then after the first assessment, there's for us, there's a nurse specialist who would routinely review that person, usually at home. How often that is really does depend on how that person's health is. So if they're completely stable and their pain is well controlled, they're getting on, they're going on holidays, they're going to play golf, it may be once a month that they're being seen. But if things change, and as things change, that could be daily. It really does depend on that person's need. What we really rely on is, if something has changed, is to let us know. So that's back to the importance of actually knowing who to contact for what, and kind of raising an alarm if there's a change, if there's a difficulty, because we wouldn't know it otherwise. So thinking about, I mentioned about communication. I think it's really important to be honest and open. And by that, I don't mean hard or brash or sort of heartless with that. But I think being open. So if somebody asks me a question, which is a difficult question, say about prognosis, how long, then I think it's really important for me to give that person the respect of giving them an honest answer. That may not be an easy answer to hear, but I think it's important to do so. But I think you should expect open communication and honest communication, but also hopefully empathetic communication, so that it's not done in a distressing way. There's an adage which I think is really important, which is to say that you can't make bad news good, but you can deliver it in a good way. But also hopefully facilitating communication between patients and loved ones. And I often find that people maybe haven't said the things that they're really worried about, either a patient or the loved ones, because both are trying to protect each other. And when you can get that out in the open, usually people's concerns, worries, wishes are all aligned, and that can be a bit of a weight off again, but that can be really difficult. And also communication between healthcare professionals, that's part of what we do, and about our sort of facilitation of someone's care. As I said, usually we're trying to protect, and it's a natural thing, and something which comes from a very good place. Usually being overprotective is counterproductive, and actually a bit more of that open, honest communication, as much as that person wants, usually is a positive thing. I think often people ask about communicating with children, which can be particularly difficult, because it really does depend on a child's developmental level. So not just their age, but their developmental level, and kind of what they want to know. So I can't say, well, a child of 11, you say this, a child of 9, you say this. It really depends on that individual. What I would urge you to do is to tell the school, and the school often have support, like their own counsellors, but even if they don't, at least they know if that child is struggling, they're gonna give them support rather than punishment, if that makes sense. What I would say is, locally to you, if you've particularly got a concern or worry about that is to speak either to your oncology team or palliative care team, because they should be able to know someone locally who can give you a bit more specific advice to your individual circumstance. But there is something there which is actually put quite nicely on Cancer Research UK about speaking with children, which might be a good place to start. So what should you ask your palliative care team? I think, again, that's very individual. What I would say is, if you know your palliative care team coming to see you, write down questions. Think about actually, well, what do I want to know? What's important? Is it practical things? Is it who do I call in the middle of the night? Is it what's going to happen in the future? Is it, well, I'm having trouble with my getting in and out the shower? It could be anything at all. So write them down. What I would say is often there are difficult questions that are almost on the tip of people's tongues. If it feels like the right time to know the answer, then I would probably say to ask that question. Again, I think if we ask a question, what I can't do is give false information to try and not upset, or because that's what I want someone to hear, because in the long run that really is counterproductive. But if you think, actually, no, I'm ready to hear this, then I would ask that question. I think it's important, whoever's in the room, to make sure that, say you're asking, how long do you think I've got, or something difficult like that, is actually making sure that everybody in the room is happy and wants to hear that information. So just a quick bit now on something called advanced care planning. So I've touched upon it a couple of times, and these are sometimes difficult things to talk and to think about. But what we're talking about in general is planning for a predicted deterioration in someone's health in the future. And it's sort of hoping for the best, but planning for the worst. So what I would say is, talking about and thinking about a deterioration doesn't make it happen. And to me, it's better done early, because you can talk and think about these things at a time when we've got time to do it, and actually we're feeling well enough to do it. Because if you're feeling unwell, the last thing you want to do is make big decisions. We know that if we haven't been able to talk about these things with people, then we probably aren't reaching their wishes. And so if we can, over time, develop some of this advanced care planning, then that's a positive thing. Some of these things may be slightly stark, but I think it's important for me just to say them now, because I wouldn't want them to be a shock if someone does talk to you about them in the future. So the first point for me is actually saying, well, what does a person and their family understand about their illness? Because if I think actually time may be short, but actually they're thinking we may have a long time, I need to bring that into line, because otherwise they're going to think, well, why are you even talking about that? The other thing, or that sort of I see it almost as a ladder. Well, okay, at the first rung of that ladder is actually, would I want things like infection reversed, and would I go to hospital to have that an infection treated? But then actually thinking about, well, if those things were not improving, or actually there wasn't anything to reverse, and this is the cancer getting worse, where would I want to be cared for? And where would I want to be cared for at the end of life? And broadly, the options would be sort of being at home or in a care home, if that's where someone is, in an inpatient hospice. Or some people actually say, well, no, I want all active treatment, and so would want to go to hospital. Another one, which is a difficult one, and I think something we get hung up on, is about resuscitation. And so what I'm talking about is, if someone was so unwell that their heart stopped or they were to stop breathing, would it be the right thing to try and intervene with chest compressions or sort of shocks with a defibrillator? And that's going to be very individual to that person. But it is something which needs to be considered at some point, because usually in the process of an illness, if somebody is very unwell with an illness which can't be treated, the chances of resuscitation being successful are very, very slim to zero. And actually it feels like the wrong thing to do at that time. But again, that's going to be very individual to where someone is in their illness. And then also there's thinking about things like wills, pensions, funerals, the planning for actually what happens after I'm gone. and what happens for me to be able to support my family, and what do I want. So it's that bit of control that people can have. These are documents that we fill out locally for advanced care planning, but wherever you are, they'll have their own individual sort of things. But the broad concept of this is actually, if we've had these conversations and we've made these decisions, if we can write them down, then that would be great, because it'll tell a doctor or nurse or a paramedic or whoever it is, actually, this is what I want. And it may be at a time, if that person is very unwell, they may not actually be able to say. So it's there in black and white, and it means that we're far more likely to be able to follow that person's wishes. And at the center of this, sometimes it can feel a bit tick box, but actually at the center of this is actually, what does this person want? What's important to them? What's important to their loved ones? So I think we've talked about a lot of this, but actually the main focus for this, or the main key element for me, is actually communication, is talking about this, talking with loved ones, so everybody knows what somebody wants, and for us to try and sort of achieve that. There are some specific documents that we can fill out. That one I've just shown there is an advanced care planning document. There's something called lasting power of attorney, where you can appoint someone to make decisions on your behalf if you weren't able to make them. And there's something very specific called an advanced decision to refuse treatment, which is where if somebody very specifically doesn't want a treatment, it's to refuse, not to say I want it. It's to say I don't want this treatment under these circumstances. You can do that. And I've just shown the form about the resuscitation. But yeah, so it's an ongoing process, but to me, I think an empowering one for patients and loved ones to be done at the right pace. Whew, right, that was a lot to take in, and I realise that's a bit of a whistle-stop tour of palliative care, and also I know the last bit, some difficult bits at the end, you know, about sort of advanced care planning. I've deliberately put them in this section because I think it's important for me just to say them. It's easy for me to do it at the end of a webinar than someone sat in the room and saying it for the first time when someone's really unwell. So that's why I bring that up. So I hope you'll forgive me if that's caused any sort of upset at all. So yeah, so now sort of your chance to ask me some questions and for me to rest my voice a little bit.
Well, we've got a few questions for you, James, so you might not get too much of a rest, but I'll go through them with you. So I'm going to combine Jennifer's questions. Gosh, sounds like a really difficult situation, but Jennifer's brother was told 1 week after finding out he has pancreatic cancer that it is incurable, and he hasn't coped very well mentally. They've asked for help with this, but been told he must answer his phone to access this, but he doesn't want to answer his phone. He just needs someone to come and talk to him. Jennifer's also asking, how do you get a bed within a hospice? So his brother is currently in bed, struggles to get to the toilet, and is eating very little and needs 24-hour care, but doesn't have a wife or children to care for him. Jennifer has been caring for him, but she's not a carer and won't be able to continue to do this. So I think, yeah, really around how can Jennifer and her family get some extra support there, James?
I mean, that sounds really tough, and unfortunately, it's not uncommon, you know, that actually things can deteriorate, and you're almost sort of trying to catch up. I think in terms of the first part of actually somebody coming to talk to someone to help from a psychological point of view, I think what I would say is depending on who's involved, we need to get someone to almost take the lead on this. And if that's the GP or the palliative care team locally, hopefully they'll be able to come out and see him. The difficulty we have sometimes is that if somebody has capacity, they can refuse. You are allowed to make what we would consider an unwise decision. So for example, if I turn up to someone's house and they're very unwell, but they don't want me there and they've got capacity, I have to respect that, even if I think I could really help here. So what I would think about is actually who are the key medical people involved here, And if there isn't anybody, I would probably go to the GP in the first instance to say, look, this is the situation, what can we do? And then pull on the different supports that are out there, pull on the palliative care team, on the district nursing team, you know, that there is that that sort of support around. In terms of the getting someone into hospice, again, I'm going to have to talk broadly. What I would do locally is, because the hospice we use isn't actually directly under our charity, it's a different charity, then we can refer directly in, but a GP can refer directly in where we work. In fact, anybody can really. So again, it's probably linking in with the person that you have got contact for and feel most at ease with saying, well, you feel actually is going to sort of try and solve this for you. If that person is not known to palliative care, I think they should be. And so if they're not known, I would probably phone the GP tomorrow and say, look, this is the situation. Can we think about palliative care? Can we what can we do here? Because it may be that actually there are things which can be done to support someone at home. So sometimes it's kind of, well, we have to go somewhere, but then when care and equipment and things is put in, it's actually, well, actually no, this is okay, but it's getting those people in. So it's with both of these, it sounds like actually getting in touch with somebody who's gonna be like a dog with a bone and try, you know, do all the phoning round and trying to sort this out and trying to get to the bottom of what we need to do. So I think if we're in the first instance, try and think about the right person to almost, sounds a bit cold, but task with this. How do we make this better? And if they were under our care, we would be coming out and reviewing and seeing what we need to do. And if we need to think about hospice, we would be looking at referring them in.
Absolutely. And just to say as well, Jennifer, you know, in different parts of the country, sometimes there is what we call palliative care spaces within care homes or nursing home environments as well. So it's not just limited to the hospice, but like James says, yeah, it's just about getting that key person involved to support you as a family. Okay, so next question. My mum has pancreatic cancer and dementia that is getting worse. So what support can we as a family access as we try and support mum?
So I think in that instance, again, I would say I'm taking that as support from mum, and not for the family, if that makes sense, specifically for the family. So what I would say is, again, the local palliative care team, the GP should be involved. When it comes to dementia, it depends on the severity of the dementia, but often physical illness can worsen things like dementia. So often the pancreatic cancer, it can be a combination, so that dementia can get worse, in which case it's thinking there a lot about what does that social care look like. Will this be managed with carers coming in, or do we need to think about how else we can manage this? So what I would say again is to make sure that there's someone reviewing mum regularly that can identify and can respond to changes in health, but also changes in the severity of the dementia, because sometimes we'll need to pull in the dementia team and use the resources that they have. So what I would say is, if you live away and somebody, you know, you're thinking, well, how is this going to work, is to identify who kind of the key person would be to speak to and to get updates and to say, well, how are things? And if you're worried, who do you call to say, well, I've seen mum, things have changed a bit, what's going on? So it's to identify that person and almost to make a kind of a contract. That sounds a bit formal, but a contract to say, well, okay, can I ring if I'm worried? Can you ring me if there's been a change? And to make sure that they've got your number. So you've got a bit of that reassurance that when you're not there, if something does change, you're going to know about it and be able to respond to that yourself as well. I hope that sort of answers the question.
Yeah, that's great. Thank you, James. We probably won't have time to do all the questions now, but we do have another Q&A section at the end. So if I don't answer your question now, or James doesn't answer your question, we will come back to it. So a message here about a mum lives over 100 miles away. She has pancreatic cancer. Mum wants to stay at home as long as she can, and she's getting incredible support locally, which is fantastic. If it comes to me looking after my mum in my own home, how do I transfer the care to my location?
That's a good one. I think so what we need to think about is what mum's care needs are. So if she's got care, then and sort of equipment needs, and by that I mean things like potentially a special sort of electronic bed or special equipment, commodes, those sorts of things, then it is going to depend on who is overarchingly responsible for that care. So if it's something like social services, then it will be contacting social services to transfer that over. That's their job. It's not your job to transfer it over. It's their job. If actually mum doesn't need care or equipment at the moment, then it would be a case of making sure that mum is registered with the local GP. And if the palliative care team are involved locally, is thinking about, well, who is the local palliative care team to me? In our team, we would routinely find that out and transfer that over, sort of almost like a handover. Not all teams will do that, but what you can do is just have a conversation with your local palliative care team and say, like, mum is coming, in a week's time. What can I expect? Can you help me? So then almost when mum gets there, the things that need to be in place are in place.
Thank you, James. So we'll probably just answer one more now. Do you need an advanced care plan as well as a respect form?
So the respect form we actually don't use in Wales. It depends on where you are, what types of forms are done. To me, there are certain ones which are legally binding. So an advanced decision to refuse treatment is legally binding. So that means that if somebody said, I'm not having this treatment or this done under these circumstances, we'd have to follow that. These plans they're not legally binding. And by that, I mean that if there was a reason or something that fell outside of what that form actually says, you could do something different as a doctor. I'd have to have a really good reason to do that, to go against it. But the main thing about these forms is just getting someone's wishes down. So it could be something as simple as just writing it on a piece of paper and signing it. And then if you've got someone coming in, that's going to add a lot of weight. To me, if I went into someone's house, if they'd just written it down, or they'd spoken to their family and said it. I mean, if they've written it down and spoken to their family, then that's essentially, I'm gonna try and do everything they want there. They've almost made my job easier because they've told me. So you wouldn't necessarily, as long as what's on the respect form is what would be on the advanced care planning form, it's essentially just duplication. As long as the wishes and the main things are written down, then that's the most important thing. And with all these forms, it feels very much like this is for the doctor and the nurse, but actually it's about the person, it's about the individual and what's important to them. So put whatever is important to you on there.
Thank you, James. So don't worry if we haven't answered your question, because we are going to come back to that. At this point, I am just going to talk for a little while about cancer-related fatigue. So just bear with me while I start that presentation. Okay, hopefully you can all see that okay. Okay, so what is cancer-related fatigue? Well, that's quite a wordy quote that we've got up there, but to put simply, fatigue can be mentally and physically draining. It can affect your everyday life, and unfortunately we know that fatigue is really common for people with pancreatic cancer. As many as 9 out of 10 people will experience at some point cancer-related fatigue. So what cancer-related fatigue isn't is just tiredness. And the reason that it's really important to distinguish between the two is because often people don't feel that it's important enough to tell their clinical teams about, or that it's just something that you must put up with. This isn't the case, so it is really important to speak to your doctor or specialist nurse if you're struggling. There are lots of different reasons why people with cancer may experience fatigue, and it can often be a combination of factors as shown in the slide, and it can have a really negative impact on you mentally as well as physically. Okay, so some of the causes of fatigue: having treatment for pancreatic cancer. As many of you probably know, it can be grueling, and although we don't know exactly why cancer treatments can cause fatigue, we know that it does. So for people who've had surgery, it's a major operation and there can be a long recovery time. So it's normal to feel tired and weak, and it can take several months to recover. Chemotherapy, commonly used, and it uses drugs that kill the cancer cells, but also it does damage healthy cells as well. And it's one of the main treatments that we use for pancreatic cancer. However, we know that fatigue is a very common side effect of this. Some people may find that fatigue starts a few hours or a few days after having chemotherapy, although it can improve when treatment stops. Radiotherapy, another treatment used, sometimes alongside chemotherapy. And again, fatigue is a very common side effect of this type of treatment, especially as people having radiotherapy often must visit the hospital every day for treatment for a period of time, and this can be really tiring. So symptoms of the cancer can also contribute towards fatigue. Some people may experience anemia, which is a low level of red blood cells or hemoglobin. And anemia can make you feel tired and dizzy and short of breath, and you may also have problems concentrating. If you have ascites, which is a buildup of fluid, often in your stomach lining, this can make you feel really swollen and heavy, making it more difficult to move around. Pain, so not everyone with pancreatic cancer will experience pain, but for those that do, this can also add to fatigue. And the best way to manage this is to treat the pain itself. Again, nausea and vomiting can also be a factor and can lead to sleep deprivation, dehydration and malnutrition. So it's really important to treat those symptoms of nausea and vomiting, and medications can be really helpful here. So digestive problems, really common for people with pancreatic cancer. Often people will need to be taking pancreatic enzymes or creon to help them absorb the nutrients from their food. And for some people, prior to their diagnosis, they may not have been absorbing food for quite a period of time, which can lead to malnutrition, but also vitamin deficiency. So we've got lots of information about this on our website, or you can call the support line to speak to myself or one of the other nurses. If you're taking painkillers such as morphine, they can make you feel drowsy. So while they don't cause fatigue directly as such, it can add to the problem. And of course, emotional factors play a huge part. So this is often a very worrying time, and it's natural to feel anxious or down, but sometimes these feelings can become overwhelming. So we understand that fatigue can impact on all areas of your life, although some people may find it more challenging than others. Also, you can have good days and bad days. So if the fatigue is caused by treatments such as chemotherapy, you can often see a pattern. You may find it difficult to socialise or not have the energy to do the things that you would normally enjoy doing. So it can impact on your relationship with friends and family. Sometimes people feel guilty if they can't play such a big part in family life. And it can be really hard to explain to others about how you feel and how the fatigue is affecting you. So fatigue can make it more difficult for people who are continuing to work because of low energy levels, and it can be difficult to concentrate. Travelling for appointments at the hospital, as I mentioned, those frequent appointments for things like radiotherapy can be difficult and leave you feeling exhausted. And it's easy to focus on what you can't do rather than what you can do, and this can make you feel really low in mood. Sometimes people have concerns and worries that the fatigue means the cancer is progressing. However, most people with all stages of pancreatic cancer at some point can suffer with fatigue. So as you can see from the slide, the physical side effects of fatigue, cancer-related fatigue, can be things like stress, exhaustion, struggling to pay attention or focus, and less commonly it can make some symptoms worse, so it can contribute to nausea and pain. So as mentioned earlier, managing fatigue, diet and nutrition plays a really important role, particularly for people with pancreatic cancer. So ensuring that you're taking your enzymes, PERT, such as creon, correctly if you have been prescribed it. Eating little and often through the day and high calorie foods can really help with your energy levels. Managing any symptoms that you have that could be adding to the fatigue. So sometimes people will be prescribed a short course of steroids to help with symptoms like pain or sickness, and they can actually be really helpful as well for fatigue in the short term, although they're not suitable for everyone, so you would need to discuss this with your nurse or doctor initially. Physical activity. So by physical activity, we're not talking about strenuous exercise, but there is good evidence to say that gentle physical activity can really help with fatigue and increase energy levels, but it's important that you don't overdo it. So we would suggest that before you start any physical activity, you have a chat with your doctor or nurse about what types of activities would be suitable for you. So whether it be a gentle walk, or there can be chair-based exercises for people that are less mobile that can be helpful. Good quality sleep and relaxation play a big part, and establishing a really good bedtime routine can help. So for example, some people find it helpful to have a warm bath before bed. It's important to listen to your body. So if you need a rest in the afternoon, then do so. If you're struggling to sleep at night time, it is important that you tell your clinical team this so that they can offer some support. Complementary therapies, again, can help with fatigue. So things like relaxation or light massage therapy. And these are often available locally through places like Maggie's centres or the local hospice. So do ask about what's available for you in your local area. Okay, and accessing emotional support. So important. So there's a type of talking therapy called cognitive behavioural therapy that can be really helpful with fatigue and sleeping issues, and it can help you as well to deal with negative thoughts, which can make fatigue harder to cope with. Finances, having concerns around finances can be an added worry, but there's lots of help available through organisations such as Macmillan Cancer Support, again, Maggie's centres and Citizens Advice, who can offer information on financial matters and benefits. So do speak to someone like your specialist nurse if this is a concern for you, and they can refer you on. For family and friends, they're often really keen to help. So giving tasks to support you, like cooking and cleaning and shopping, means that you won't be using all your energy on household jobs, so that you can have that energy left to do the things that you really enjoy to do. Sometimes health professionals like occupational therapy can become involved, and they can help you to include activity in your daily routine and provide equipment as well that can help you manage around the home and stay independent as possible. And keeping a diary for managing fatigue is a useful thing to do. So you can find a really good example of this in our fatigue booklet, which you can download from our website, or you can also order a paper copy for free. And for those of you that are caring for someone with pancreatic cancer, it can be really upsetting to see them struggle with so little energy and to feel low. And it can be exhausting for you as well. So do reach out for support from others and speak to the health professionals involved in your loved one's care for more support. Okay, I hope that's been helpful. I am going to hand you back now to James, who's going to talk about end-of-life care. As we said, we do understand that you may not want to stay for this part of the session, so do feel free to grab a break instead if you need. And then the final Q&A section will start around 7:20. Okay, and I'll hand back over to you, James.
Lovely, thank you. Yeah, I mean, fatigue is a difficult one. It's a difficult one, and probably underreported and undermanaged, because I think people think, well, it's to be expected, but you know, there are things that we can do to help. Right. As Nicola has said, the next part is going to be about end of life care. It is, I think, for the people who are staying on, it is, it's sort of not fluffy. Is probably the way I'll say it. It's practical and it's honest about my experience of looking after people with cancer at the end of life. I'm just going to share my screen again. Hopefully, can you see that, Nicola?
Sorry, James, I was still on mute. Yes, yeah, we can see slides. Sorry.
Thank you. No worries, no worries. Thank you. Right, so this slide is just to looking at, and it's an oversimplification, but it's looking at what happens to people as they approach end of life and sort of recognizing signs of end of life, of approaching end of life. It's very oversimplified because it says that, you know, people with certain illnesses only have that illness, but in essence, if you look in the top right hand corner at someone with cancer, if they've otherwise been well prior to this and then they're deteriorating and there isn't anything that can be done to treat the cancer and the cancer is progressing, we tend to see a stepwise progression, a gradual deterioration in someone's function and someone's health over time, and that can help us predict that actually things are changing and we need to start planning and thinking and getting ready for end of life care. And that's not just for the individual, but that's for the people around that individual as well. Prognosis is a really difficult one, and when someone asks me how long have I got, I always say, look, we're really bad at this, because I think often people are told that if you have this type of chemotherapy, it'll give you 3 months more, and you were told the prognosis was 6 months, so then it's 9 months. It doesn't really work like that in terms of in reality. So I think I personally don't give numbers because I think it can be misleading and can be confusing. The thing that I'm guided by most is actually that speed of deterioration. So if things are deteriorating month by month, the prognosis is likely to be months. If it's week by week, weeks, day by day, days. Again, it's only a guide, and there are, you know, some people surprise us and actually they live longer, or there's something that can be treated like an infection and we've seen a deterioration, but actually it was that infection and then things pick up. Equally, things can be going on okay, and then suddenly something can happen and there will be a rapid deterioration. But in general, that's a good guide as to what we usually see. And so hopefully for you, either as patients or relatives, if that's really important to you, then looking at that progression is important. It also then should act as maybe a trigger to think, well, if things are deteriorating, we need to plan for this. What does someone want? So that trigger for the advanced care planning is in place, and that support is also in place. But also, if somebody asks me about prognosis, one of the first things I ask is, well, why is that important? And it seems like a strange one, but often we're sort of hardwired that, you know, you see in films and on TV, well, how long have I got? But actually, why is that important? Is the number important, or is it more important what we do with that time? So for some people, if time is short, it's actually about some of that financial planning, or they want to go on a holiday or something like that, and that might then be the focus. So usually when I'm talking about function deteriorating, it's talking about how someone is managing day to day. It may be that a month ago they could walk to the shops unaided. Now they're struggling to get out of the house. That's a significant change in function. They may start eating and drinking less and spend more time sleeping. Obviously, we've just spoken about fatigue, but you know, spending most of the day sleeping, not eating and drinking very much. Sometimes we see, especially towards the end of life in the last days or weeks, potentially some periods of confusion. Sometimes people's legs can become swollen. It's important to say that if we see these in isolation, but everything else is okay and someone is otherwise functioning well, then I wouldn't necessarily think, oh, suddenly we're approaching end of life if we see them in isolation. It's usually all of them together, or we're just seeing, you know, a gut feeling is a good thing, you know, is a good thing to say, well, actually, I'm not happy, things are changing. Usually towards the end of life, I'll be looking at someone's medicines to say, actually, is this helping them feel any better? If it's not, then why am I making them take them? So things like statins, which are there for cholesterol, when someone's in the last days of life, it's not going to hurt them stopping them. And actually, I think I'd rather not have to take tablets that I don't have to. Usually when we're seeing that change, usually we'll ask for a review, a medical review, just to make sure that we're not missing anything here. Is there anything on their blood test that may be reversible? Is there anything like an infection? I've got to sort of caveat this with the fact that what's really important is, if we've done that advanced care planning and someone has said, do you know what, I don't want anything done, and that's okay to say that, then we won't go looking for it, and we'll be focusing on that comfort aspect. Then if someone is in the last days or short weeks of life, we will be looking at, well, actually, where does that person want to be cared for? If it's in the inpatient hospice, if they've got beds, then we will refer someone to the hospice. If they wish to stay at home, then I'll talk a little bit about the things that usually we will put in place. If somebody wants very active treatment and there may be something reversible, they may go into hospital, but I think we'd have to accept that they may deteriorate in hospital, and there may not be anything we can do to prevent this. So if somebody's staying at home, the most important thing for me is actually everybody recognizing where things are, and to be as comfortable as we can be with actually the plan is to stay at home. We would usually put in place medicines. I think I mentioned it briefly earlier, but medicines which can be given under the skin, usually by the district nurses, for symptoms, for pain, sickness, restlessness, if somebody gets chesty, and these things are there. We don't rely on somebody having to take them by mouth, because if somebody's very unwell, then usually they can't take it by mouth, they can't swallow the medications. Sometimes we start something called a syringe driver, which is a box of medicine with a syringe in it with different combination of medicines for symptom control. We don't always need that. Often people are worried, they think that shortens life, because they often see people with them at the end of life, but it's sort of the chicken and the egg. I think that we use them when someone's approaching the end of life. It doesn't shorten someone's life. We would, specialist palliative care team would be there to support and monitor symptoms, but we're also involving the GP and the district nurses. And if we think about that function deteriorating, and the fact that in the last days of life, usually someone is spending most, if not all, their time in bed, we need to almost bring the things that they need into that bed. So we usually put in place something called a hospital bed, or an electric bed, where you can press a button and it can put someone in a comfortable position. Things like pads, potentially a commode if they can get out. So things to manage personal care in the bed. We would also look at care. Some families say, do you know what, we're comfortable in doing this, we want to do this. Other people say, no, that my loved one wouldn't want that. And it's okay to say, I'm not comfortable in doing that. So to have care come in, usually 3 or 4 times a day, to come in and manage that personal care. It is important for me to say, in most places, there wouldn't be a medical professional in the house, or a carer 24 hours a day. That may be different where you are, but if we've got the other things in place, 9 times out of 10, it goes fine, and somebody passes away peacefully at home. And usually at that time, we would have something like the respect form, or in Wales, we would have a do not resuscitate form in place, just to stop something inappropriate like resuscitation happening after someone has naturally come to the end of their life. In the last hours to days of life, usually we see someone who's very sleepy or unconscious. We usually, we should see people's symptoms well managed, and if they're not, then it's our job to do our very best to get them better managed. The reason I can't say 100% we always get it exactly as we would, because sometimes things change very quickly, but we will 100% of the time try our very best to get people's symptoms well managed, and the vast majority of the time they are. Occasionally breathing can become noisy. It sort of represents someone who's so fast asleep and unconscious that they're no longer coughing up the things off their chest. So usually the patient isn't aware of it, so it's worse for the family. You can use medicines for it, but if that is present, as long as the person, what I explain to families is, as long as the person doesn't seem distressed by it, they're not aware of it. A very common worry in the last days of life is actually my loved one isn't eating or drinking at all, or very little. This is actually a natural part of approaching the end of life, and there's evidence to say that sort of supplementing fluids under the skin, it usually causes more issues, and there's no evidence that it prolongs life in any way. But what I would say is, if you've got any questions, just to ask. There are practical things that you need to think about of what to do after someone dies, and they seem very cold, but from my experience, actually asking those questions and discussing those things means that process is going to be a lot less distressing and hopefully peaceful, and as natural and as least distressing as possible. So I'll do my take-home messages and then come back to the Q&A. So hopefully I've got across the palliative care, to see palliative care as a positive thing. And I think one of the questions alluded to, well, when should palliative care be in place? Often with people with pancreatic cancer, we'll see them early. So we'll see them when they're still having their treatment, because we may not be doing a huge amount at that time, but we're there before something becomes a crisis to try and manage that. Again, planning early avoids crisis and gives a person a voice and allows them to be part of their care, even if it's difficult for them to tell us at the time. And there's lots of support available, that I think a few of the questions I've had a look at have said, well, we've really been offered palliative care, or we don't know who to go to. What I would say is if in doubt, a default would be the GP. If there is no one else, or a key worker, or the Pancreatic Cancer UK sort of helpline, I'm sure would be able to help. But just make that call. It might be that's the most important thing you do tomorrow, is make that call to get the ball rolling, to have the support in place that you need. And what that support looks like for you or your loved one, and what that support looks like locally to you may differ, but at least you've got, you know there's someone there, there's someone in your corner and someone you can contact and trust. So those are sort of my take-home messages. I hope it's been helpful. I know some of the things we've talked about have been difficult, and it's a real whistle-stop tour. There's a lot to take in, but I hope that this has answered some questions and hopefully dispelled some of the worries about palliative care, so that ultimately my job, the reason I get up in the morning, is to try and make people's lives better. That it may be that their life isn't very long, but we can make it better. So that's hopefully what all the healthcare professionals you interact with, that will be at the heart of what they want to do. So thank you for having me, and I'm happy to answer any more questions.
Thank you, James. That was really helpful, and I'm sure a lot of people out there had a lot of questions answered during those sessions. We've got quite a few questions. We're probably not going to get to them all, unfortunately, but just a reminder that you can contact us on the support line with any questions that you may have, and we'll certainly do our best to answer them. Okay, so the first question is around how quickly a patient should get a palliative care team involved. My dad was diagnosed 3 weeks ago, told nothing can be done, has been given a prognosis of around 2 months, but hasn't got a team in place.
I mean, I would say in that situation, probably now, I would say. There are a proportion of patients that if they're doing incredibly well on their treatment and things are completely stable, occasionally we'll take a step back if we're literally doing nothing over the course of months. But in that situation, I would say actually to get in touch with somebody, probably the GP, to say, look, can you, we've been told this by the team that have diagnosed this, can we get palliative care involved? And that just to get those links made.
Thanks, James. We've actually got a couple of questions around ascites. One of the questions is quite specific around prognosis, but I would say that's probably a question for Mum's clinical team. It would be difficult to answer that, obviously, without assessing Mum fully. So I'm going to put those questions together and just ask for information around managing ascites. That's okay. My mum has terminal pancreatic cancer that's now metastasized to the liver. She's developed ascites. Told last week there wasn't enough fluid to drain as complications with the liver. She's comfortable at the moment and still eating a little bit. Can you give us some information on ascites?
So, I mean, ascites is a fluid buildup in the abdominal cavity. We've all got a little bit of fluid there to allow things to move around. But when it builds up, because of pancreatic cancer, because of the inflammation, it can build up to the point of being uncomfortable, causing people to feel sick, and causing pain. The thing that I would be guided by most in terms of draining it off is someone's symptoms. So if they've scanned it and there's not enough to drain, then actually it sounds like it's not causing too much problem at the moment. It's something to keep an eye on, and if there's further symptoms, is to get it looked at again. So not to say, well, okay, it's fine. It can build up over time. For some people, there are certain water tablets which can help, but that's a specific group of people. Usually what people will have is a drain put in. It sounds quite scary, but it's just a small tube which goes into the abdomen, usually left in for about 6 to 8 hours, drains off a certain amount, and then someone feels better. It's actually, you can hold a lot of fluid in there. So usually drain about 6 to 8 liters. That's often not all of it, but it's more than enough to make someone feel better. I think the most important thing here is not to worry too much about the fluid being there. It's more about actually what effect is that fluid having on that person's quality of life. So if you can drain some of it off and they feel better, great. And that can potentially be repeated. Sometimes they put in things called long-term drains, where it'll be in there. It could be, they don't have to go in to have the procedure done, but it depends on the individual. So I wouldn't, in that instance, it's a matter of keeping an eye on it.
Okay, great. Thank you, James. Okay, so there's a question here about my dad was diagnosed with stage 4 pancreatic cancer back in April and was given around 6 months to live. At first, we were being well informed as his children. However, Mum is the primary caregiver and she's keeping information and not giving the children a true update of how he's doing. To summarise, are there signs we can look for or other coping mechanisms we can utilise since we're not being let in on how he is truly doing, so that as his children we can prepare ourselves through this grief process?
So I think hopefully some of the information on the on seeing that change hopefully will be empowering there, because if you're seeing that change, I think you'll instinctively know yourself that things are getting worse. The other thing I would say is, and I don't have an answer for this because it's very specific, but is maybe to speak to mum and dad as to why that information isn't being shared, because often, back to what I was saying about being kind of, we try to protect people and we're worried about the impact, but actually that can be counterproductive. It may well be that sort of it's a classic case of that, and actually it's to say, look, we want that bit more information, and also to find out. For me, it would be finding out, if I was going in to see dad, I would be saying, look, what information do you want shared with who, and to kind of to try and work through that. I personally, I would be trying to find a way of everybody getting the information that they need, because I find that just makes it easy. And you mentioned about the sort of grieving process. Sounds cold, but after someone has passed away, these unanswered questions or things which hang over are really difficult. So I think that for me, the first step here would be trying to understand why that information isn't being shared. Obviously, without knowing relationships and things, it's difficult to go into more detail, but I think that would be the first step for me. But for yourselves, if you can't get specific information, then it's about seeing the physical deterioration, you know, and seeing how quickly that's happening.
Yeah. Thanks, James. We've probably only got time now for one more question. It's just a quick one about oxygen given it end of life. So is there a chance it can make breathlessness a bit worse rather than better?
Oxygen's a funny one. So there's no real good evidence that as long as somebody's oxygen levels are within normal limits or not very low, it doesn't really, there's no good evidence that it helps. So I think people get in hospital routinely. Usually other measures are far more effective. So we use medications and non-medication measures, making sure the room is cool, using a fan, using breathing techniques, and morphine medicine actually we use for breathlessness because it works very well. Usually that's much more effective than oxygen. Sometimes we'll prescribe it. I wouldn't prescribe it for someone who's in the last days of life, but prior to that, if someone's found a benefit from it, even if their oxygen levels are normal, I probably would carry it on, but it would be the other things that I would be going to first, because for me, they work better.
Thank you, James, and apologies if we didn't get to your question. As I think one of our team have just popped in the chat, contact us please on the support line, because we will certainly do our best to answer any outstanding questions that you may have. I'm just going to attempt to share my screen again. Hopefully you can see that. I just wanted to talk briefly about the other sources of support that we have out there. So one of the things that we do as a charity, we have a free wills service. That's with Fairwill. You can find all that information on our website. So if that's something that you need more information on. So we've partnered with two organisations, Fairwill and the National Free Wills Network, to offer people the ability to write a will for free. So you can do that online or speak to a solicitor in person through the National Free Wills Network. There'll be no cost and there's no obligation to leave a gift in your will. The legislation is different in Scotland and Ireland, so the online service is only available to people in England and Wales, but wherever you are in the UK, you can make use of the free in-person service. And I just wanted to, I've skipped a slide, I'm afraid, but I just wanted to touch on other charities that offer support, and that is things like Macmillan, who you're probably familiar with, Maggie's Centres that I mentioned earlier, Marie Curie, and I know we will have lots of people who are caring for loved ones with pancreatic cancer, so I've just popped Carers UK on there as well, and they can offer support for you as carers individually. Okay, so that brings us to the end of our session. All's left for me to do is say a big thank you to you, James, for coming along and talking to us about this. I think it's probably been really helpful to a lot of people. I do hope all you attendees have found it helpful, and please let us know via the feedback form that will be sent out. The recording of the session will be uploaded on our website in the next few days, and just another reminder, our support doesn't stop here, so contact us on the support line. We are closed in the morning, I'm afraid, for staff training, but we'll be open again from 1 o'clock in the afternoon. So if we didn't get to your question, please get in touch. Okay, so thank you again, and good evening.
Thank you. Thanks for having me.
Thank you.